So I'd like to talk with you today is about liver surgery, particularly spend most of my time talking about ablative therapies or destructional therapies, and talk about some of the fun things we do in the lab. Now, of course, every speaker is going to have their basic slides. I'm not going to waste anybody's time because you guys all know this stuff very, very well. But if you look at the very last line, as a liver and pancreas surgeon, that's all I do is liver and pancreas surgery. I don't do anything else, and we're ridiculously busy. But you can see that we only contribute a very small amount of care to those out there with neuroendocrine disease, particularly when it comes to pancreas. Whenever anyone is dealing with a cancer, particularly from the physician or the provider point of view, it's very important for us to understand the biology of this disease and understand whether they're dealing with a local disease, a local regional disease, or a systemic disease. Because the therapies that we provide are going to treat tumors at different levels. So understanding the biology of disease and choosing the appropriate therapy or therapies for a particular stage of disease is critically important. Now, when it comes to neuroendocrine disease, most of what I take care of is metastatic disease to the liver. And as we all know, the survival for patients with metastatic neuroendocrine tumor to the liver, isn't so good. A little bit better than some of the other diseases that we treat. But again, I think we have an opportunity to do better. And as you can see here, through very aggressive interventions such as liver resection, primary tumor resection, lymph node dissections, and the other therapies that we can provide, I think we can make a significant impact in terms of symptoms and even survival, as you can see here. Now, when it comes to people with neuroendocrine liver metastases, there are a variety of treatments that you've been hearing about for the past 2 days. We have systemic therapies, we have regional therapies, and then we have surgical liver-directed therapies, in particular resection as well as ablative therapies. Now, I'm not a medical oncologist. We've been hearing some wonderful discussions about some of the newer agents that are out and available now, and it's probably beyond my scope of practice to talk about those in any meaningful way. We just had a great review about transarterial therapies, bland, taste, tire, dead taste, and whatnot, and I don't think we need to cover that anymore. I'm the surgeon, so what I'd like to talk with you about is liver resection as well as liver ablation. Now, I will forewarn everybody in the room that I'm intending to show some videos and some pictures that might make people feel uncomfortable. And I want to be sensitive. I want to be sensitive to your sensitivities. So if this is too much, it's relatively rated G from a surgical point of view. But again, I want to keep it. I want to be sensitive to your wishes. If it becomes too much, just raise your hand or something like that. We'll move on to the next slide. So when it comes to liver resection for metastatic neuroendocrine cancer, you can see here through a long history of studies that we can have a very positive impact in terms of symptom control, as well as overall survival, whether that be disease-free survival or overall survival. Now, when everybody thinks about liver surgery, this is traditionally what most people think of. It's these big, large operations and retractors and bleeding and blood, and sometimes we still need to do that. But fortunately, as with surgery, a lot of what we do now is becoming less invasive. Now, hepatobiliary surgeries kind of lag behind general surgery when it comes to minimally invasive. But here at Carolinas Medical Center, we're actually at the forefront of minimally invasive hepatobiliary surgery, and that's what we train fellows and actually we train attendings in terms of how to do this. So really laparoscopic liver surgery has taken off since in the United States to some volume in 2008, and I want to credit my friend Joe Buell, who's the chief of transplant at Tulane, for really organizing those who were involved in laparoscopic liver surgery at the very beginning from all over the world and pulled us all together in Louisville for a very significant consensus conference. Now here's a video, so everybody hold on. Now this is a patient here you can see with a tumor in the left lobe of the liver. This is about as straightforward as liver surgery gets, so again, keeping it very light. You can see that's the liver. We're looking at it from the belly button up. The diaphragm is up on the top. And I think you don't need to be a physician to appreciate that there's a tumor there in the left lateral segments, which is part of the left lobe of the liver. Now, we have very specialized instruments and devices, and there's been a huge evolution in terms of how we actually do laparoscopic liver surgery over the past 10 years. So the first thing that we do is we mobilize the liver. The liver is attached by a few ligaments to the diaphragm and to other parts of the body. And then once we map out where we need to do the resection is primarily based on blood supply. So when we're looking at scans, particularly with patients, a lot of focus tends to be on the size of the tumor. For the liver surgeons, the size most of the time doesn't matter. It really depends on the location of the tumor and where that lesion is relative to the blood vessels going in and the blood vessels going out of the liver. As I mentioned, as we start going through the liver parenchyma, or the tissue of the liver, there's been a huge evolution in terms of how we do that. We used to use radiofrequency ablation devices, then microwave ablation devices, and now we use vessel sealing devices to come across the liver. It doesn't work for everything in the liver, so we need to be very selective about what we divide with energy devices and what we divide more formally with stapling devices and other methods. So as you can see here, we just slipped in a stapler, and we try to take the major vascular pedicles, whether they be inflow or outflow pedicles, with staplers, and we tend to take the liver tissue itself with a variety of energy devices. I'm not sure if there's any one that's better than the other, and it's usually based on the user's preference. How are we doing? Everybody comfortable with this? Okay. I have a lot more bloody ones if you want to see those, but we'll keep it light. So again, and as you can see here, here's how we march through the liver. And we can do this very effectively. And this has been a huge advancement in terms of hepatobiliary surgery, because the recovery, there's no difference from a cancer operation, but there is significant improvement in short-term outcomes, particularly with pain, wound complication rates, wound infection rates, and length of hospital stay, and overall decreased morbidity. So we are very strong advocates of laparoscopic and minimally invasive liver and pancreas surgery. And again, we're going to continue to evolve these techniques as the years go on. So unfortunately, as much as we like to resect livers, most of the patients that we see are not candidates for complete liver resections for a bajillion reasons. Many times because the disease on both sides of the liver, there's major vascular pedicles involved. So lots of different reasons, and most of the people that we see can't have definitive liver resections. So we have to develop other technologies to help treat patients with liver-only or liver-dominant disease. And so that's where tumor ablation comes in. And tumor ablation, meaning rather than taking the tumor out, what we do is we destroy the tumors. And so we have lots of different methods, and there's been a huge evolution of ablation devices over the past, say, probably 30 years. And so there's all sorts of ways of destroying things. We're the destroyers. We can use alcohol by putting it directly into the tumor and not drinking it. We can use stereotactic radiosurgery. There's some newer kids on the block, but I'm going to focus on just a few things. I'm going to focus on radiofrequency ablation, microwave ablation, and IRE, or irreversible electroporation, which we do all of. Now, I've spent my entire professional career developing ablation devices. So every radiofrequency device that's out there, every microwave device, I've had a hand in its development one way or another. So my earliest experience with cryoablation was when I was a medical student at Brown. Was operating with this crazy surgeon, and we would cut out as much liver tumor as we can and actually pour pitchers of liquid nitrogen into the holes that we created into the liver. I'd like to say for everyone, we've come a long way since then, and with the development of insulated cryoprobes, as you can see here. And I'm only talking about cryoablation from a historic perspective, because there really is minimum role for this. But we did learn a couple of lessons along the way. One is we developed insulated, and we went through different cryogens from nitrous oxide to liquid nitrogen to argon gas and a variety. But one of the important things we learned is that we could start doing this in a minimally invasive way. So we were the first people to ever publish on laparoscopic cryoablation. And again, we've learned some important lessons that translates to what we do today. The other important lesson that we learned is from a cancer point of view. So this is not neuroendocrine, this is metastatic colorectal cancer. But remember that cryoablation and other liver-directed therapies are local or local regional diseases. Metastatic colon cancer to the liver is a systemic disease. This paper was published back in 1998, before the days of good effective chemotherapy for metastatic colorectal cancer. And you can see here that we have long-term survivals for patients with a systemic disease with a local therapy. And that's really important. And that's really part of understanding the biology of disease in terms of what treatments are appropriate for which diseases. So we're well away from cryoablation. Now what we use is electricity and other things. And I'm going to skip over that. And we've been using electricity or electrosurgery since the early 1920s, pioneered by Dr. Cushing and Bovie. This is sort of an old school video of Dr. Cushing, who was a neurosurgeon, at Mass General Hospital, working in concert with a physiologist or electrophysicist, Mr. Bovey. And this is one of the first Bovey pencils. It's a very common device that we use in surgery today. But this is what they did back then. This is, he's going to open it. You're not going to see the brain or anything, so don't worry. But you'll see some old school surgical techniques here. Before we had electrosurgery to control bleeding, you can see there's about, I don't know, 100 snaps there. And the way to control bleeding was to snap a blood vessel, put a half twist on it, and then just keep on putting multiple snaps. We've come a long way since then, and here he is putting, using the Bovey device now, which is common in absolutely every operating room throughout the world these days. There's, there they are, there's the first generator. And so again, and there it is. So again, we've come a long way since then, and we've learned a lot of lessons along the way about energies. And this is just a nice little timeline for everybody in terms of energy. What we learned is that tissues can tolerate temperatures up to about 45 degrees Celsius, and above 50 degrees Celsius, it's cytotoxic for the cells. So we've started developing other thermal sources, including laser ablation, microwave ablation through the 80s. And then the important timelines for us is that radiofrequency was FDA approved for liver use in October of 1997. So we've been doing RF since then. And then actually microwave was FDA approved in 2003, but became commercially available in 2008. I started doing microwave ablation in 2003 and have never looked back since then. How does radiofrequency ablation work? It works by passing electric current through your body. And what we do is we have grounding pads on your legs, generally 4 grounding pads on our legs, and we push about 1 amp to 2 amps of current through your body. And then it really comes down to the current concentration. So at the very tip of the needle is very high energy density, which vibrates the local ions in the area, which generates heat. And we then destroy tumors that way. There are different systems that are out there, and it's important for the user to know the strengths and weaknesses of each system. But what we learned through our experience with radiofrequency ablation is that for larger tumors, even in our own experience, the most busy ablaters in the United States, that even tumors above 3 centimeters, above 6 centimeters, our efficacy for using that particular device wasn't quite as good as it was with smaller lesions. And so I've spent years in the lab with our team trying to enhance radiofrequency ablation, multi-probe ablation using allogeneic gels, ferrous oxide solutions into the liver. And our conclusion today, when it comes to monopolar radiofrequency ablation, is that it's a dead technology. I think we all need to move on. And so it served its purpose. It's a huge advantage over cryoablation. But again, I think we have better things nowadays. It makes much more sense than rather passing a current through your entire body to pass it between electrodes. That's bipolar radiofrequency ablation, not really in huge use. And everything is really given way to much higher energy systems. So down here on the electromagnetic spectrum, radiofrequency is down low in the radio wave range. If we think about higher frequencies in the microwave range, like 2.45 gigahertz, which is the same as the microwave in your kitchen, or 915 megahertz, which is the same as your cell phone, or even higher frequencies, 9.2 gigahertz, we can maybe make some new differences. Now, the difference between microwave and RFA is in RFA, you're passing an electric current through one's body. With microwave, you have a microwave generator, you have a cable which goes to a needle, and actually the microwaves are emitted off the end of the needle. So there is no current passing through your body. And so the basic premise is the frequency and the size and shape of the antenna dictates a microwave near field. And unlike radiofrequency ablation, everything in that microwave near field gets destroyed. If your hand is in that field, even if you have a rubber glove on, it gets burned. If there's air, and it will cross an air gap and destroy what's on the other side. If there are blood vessels, bile ducts, anything will be destroyed within the microwave near field. And so it's really important to understand the technologies. And then what you do is you create this large thermal mass, and then through conductive heating, the peripheral tissue around the microwave near field will heat up to give you your final ablation zone. So unlike radiofrequency ablation, which is susceptible to everybody what's called a heat sink, which is not actually accurate, there are 2 types of sinks. There are electrical sinks and thermal sinks. An electrical sink means that the current gets taken away. Say there's a tine that's out in a hepatic vein or somewhere else, the currents can get diverted so the tissue doesn't get destroyed appropriately, or a thermal sink where flow through vessels will take heat away to keep the tissue cool and might not achieve complete coagulative necrosis of that area. Where microwave near field is not susceptible to either of these sinks, however, that peripheral zone, that orange zone, can be susceptible to a thermal sink from large vessels in the area. This was the first microwave system ever used in the United States, which we did, and it was pretty scary for us when we actually did it. And we've done a lot of work in the lab looking at time and power to figure out what are the proper power settings. And this is just a typical microwave case. It's not quite as exciting as a liver resection video, but this is typically what we deal with. This is obviously somebody who's had previous surgery, a previous bowel perforation, lots of adhesions. This person had chemotherapy. That's what a chemotherapy liver looks like, this fatty, soft, not happy liver. And again, one needs to have patience and perseverance to just continue to work your way through all the adhesions to get things free. And we have a lot of different devices and strategies and port strategies to try to achieve that. And then once we get all the adhesions taken care of, then what we need to do is assess the entire liver. Now, oftentimes when we go into surgery, we know where the lesions are. But unfortunately, many patients, particularly patients with neuroendocrine disease, will have more disease in their liver than we appreciate despite the best preoperative imaging. And that's probably the norm for neuroendocrine. So it's our real job is to actually look for other disease that we don't know is there. So we spend a lot of time ultrasounding, because still intraoperative ultrasound with an ultrasound probe directly on the liver is still the most sensitive way to look for disease within the liver. And you can see we passed the microwave needles through. We figured out that we can monitor the real-time microwave field. And again, for this particular individual, we felt this was the best choice for them for a variety of reasons. And you can see here, we're just taking out the needles. We burn on the way out so we don't cause any bleeding from the needle sites, and also not to seed tumor along the needle tracks as well. So we routinely will burn on the way out as well. We're going to treat this one for a second time. And what we see in the operating room is the tumors turning brown and black and bubbling and smoking. And so it's a very good visceral feel that you've really damaged something. And so just unlike radiofrequency ablation, where there seems to be a perception, even amongst medicine, that we cannot effectively ablate or destroy things above 3 centimeters, that's old data. And even again, within medicine, that still persists. With modern microwave technologies, we can destroy your entire liver if we wanted to. I'm not saying that we should. And so this is an example of a patient with a large tumor in the right lobe of the liver, and you can see that we could almost effectively destroy the entire lobe of the liver. This is not for everybody. It's just a demonstration of what can be done with modern ablation technologies. Lot faster than radiofrequency ablation. And there are 2 main frequencies out there now. There's 915 megahertz and 2.5 gigahertz. They both behave a little bit differently. This is a 9.2 gigahertz experimental probe that I think I have the only generator in the United States in my garage. That's what I do on the weekends. And there are differences in the frequencies. You know, the lower the frequency, the lower the energy per wattage. However, it has a deeper depth of penetration. The higher the frequency, the higher the energy, but the smaller depth of penetration. So you have to pick and choose what is the right frequency for that particular application. When we compare 915 versus 245, for the same amount of power output, you can see we can carry out the ablations in half the time with 245 than 915, because for the same amount of power, it's twice the energy, because it's twice the frequency, right? Basic physics, good. When we look at the approach to ablation, and this is one of the patients' papers we were co-authors on in the Annals of Surgery last year, we found that those patients who were treated with either open, which we almost never do, 95% of our ablations are laparoscopic, or through a laparoscopic approach, had a better overall result and a lower local recurrence rate than those patients that were treated with percutaneous ablation techniques. And I'll show you a good example of why that is. Again, this is part of the same paper, and the green dotted line demonstrates patients with metastatic neuroendocrine disease tended to do a little bit better. But again, good long-term survival for a local therapy treating a systemic disease. We haven't ended our work with microwave ablation, and this is my fellow, a second-year fellow currently, and you can see we work a lot on antenna design and matching, tissue permittivity matching, and there's directional antennas, broadband frequency generators, and so there's a lot of work that we actively do in the lab to try to make the technology better. For sake of completion, there are other thermal ablation modalities out there. There's laser ablation, which is only available, I believe, in Australia and Germany. And then HIFU, which is high-frequency ultrasound, which is a non-invasive way of putting high-frequency ultrasound to thermally ablated tissue. And actually, the only company that makes a laparoscopic HIFU probe is across the street from the hospital. It's not ready for prime time yet, and it's still in clinical trials. And the newest kid on the block is IRE. Has anybody heard of IRE yet? Anyone? Anybody had IRE? I don't want to ask anything personal. There we go. So IRE is sort of the new kid on the block, and we do all of these. Now, it's a little bit different than microwave. It's multi-electrode needles are placed, and it's direct current. And what we're using is very high voltages. We're putting across anywhere from 2,500 to 3,000, 1,500 to 2,000 volts per centimeter. We generally space the electrodes anywhere from 1 centimeter to 2 centimeters apart. So we may be putting 3,000 volts between electrodes, and we're pushing a lot of current. When I said radiofrequency ablation, which is a lot of energy pushing through somebody's body, that's around 1 to 2 amps. So we're going to be pushing anywhere from 25 to 40 amps of current between those electrodes. These are very high energy, very powerful devices that need to be used very carefully. I'm going to skip all that. And what we try to do is we need to hit the sweet spot. If we don't treat enough, then we're not going to effectively porate the cells. If we treat too much, then we'll get into the thermal range. And there are some tissues like pancreas and some blood vessels that don't like to get heated up so much. So we need to try to find that sweet spot. And it's very technical. It's a very technically difficult thing to do, is to get the pulses and the energies just right, to look at the change in amperage. This is what our typical OR looks like. You see on the right, there's a ultrasound machine. In the middle is an IRE machine. On the left is a microwave generator. So we have everything here because we do a lot of liver surgery. And this is actually a screenshot of one of our patients. And this is what we see, where every line is a pulse. And what we look to see is we generally start off with we want a baseline amperage of about 15 to 20 amps. And then as we pulse about 90 pulses for that particular base pair, we want to see an increase of that current by about 15 amps. And then we know to a reasonable degree of medical certainty that we've adequately treated that tissue. Now, the way to think about IRE is this. So we have 2 electrodes, and what we're doing is just streaming electrons between those 2 electrodes. And so this is a video clip. Hopefully there's no copyright issues there. I'm going to get in trouble for this. But this is sort of a nice visual way of thinking about IRE, where the debris field is coming streaming across and then just annihilating everything in its path. So I think you guys will like that one. You can hold back your applause. It's all right. It won't come back. There you go. So that's kind of the way we think about IRE. And the nice thing about IRE, unlike the thermal ablation methods like radiofrequency and microwave, is that we have a very clear demarcation line, and it preserves the blood vessels. It preserves the arteries, veins, and bile ducts. So that opens up some more opportunities for us potentially for treatment. So what are the potential roles for IRE? So it's FDA approved for any soft tissue ablation, but for pancreatic tumors, now I've cryoed, RF'd, and microwaved pancreas, whether it be intentionally or unintentionally, and I can say that doesn't go so well. So we primarily use IRE for ablation of pancreatic tumors, and then anything adjacent to a vital structure like a main vein, a main artery, or something like that, and I'll show you quick examples. Any of the surgeons in the room would appreciate that this is a disaster. This is a patient with a pancreatic tumor, and that white squiggly line is the superior mesenteric artery, and we have tumor all over the origin of the superior mesenteric artery. That is the one artery that feeds your entire blood supply to your intestines. So if anything happens to that artery, you will not survive. And so we need to try to aggressively treat that cancer, but preserve that blood flow. And so this patient, you can see here the needles in place, and we have to very carefully thread those needles just along each side, left, right, front, and back of the superior mesenteric artery down to the aorta, and then we pulse energy between those electrode pairs. And this is what I see in the operating room under ultrasound, and this is what I need to work with. That big black line on the bottom there is the aorta, and the sort of, you'll see coming in and out of the field, the dark lines, which is the superior mesenteric artery and the celiac axis, which are the main arteries coming off the aorta. And I have to very carefully try to thread that white hyperechoic needle along each side of that artery down to the origin of the takeoff of those vessels. How are the surgeons in the room feeling about that one? Comfortable? That's what? It's horrifying. And then this is what it looks like afterwards. And so that might look like cancer, but that's actually porated tissue several months out. And if you did a PET scan on that, that would not enhance. So again, we're developing experience with IRE. The person who has the largest experience with pancreas in the United States is a friend, Rob Martin, in the University of Louisville. And when you compare patients with locally advanced pancreatic cancer, not pancreatic neuroendocrine, who would traditionally be treated with chemoradiation, if you add IRE, there seems to be, in the short term, some improvement in overall survival. So what are the roles for IRE and neuroendocrine malignancies? Well, again, non-resectable pancreatic tumors are those who wouldn't be a good candidate for a pancreatic resection for perhaps medical reasons, enhancing a surgical margin in a thermally sensitive area, and particularly what we use it for is vascular involvement, so along those main arteries and veins and hepatic veins. So again, this is a quick example of an active patient right now. The white big circle is the aorta, the smaller white line is the superior mesenteric artery, and you can see this is very typical of a neuroendocrine tumor, and somebody else showed it earlier today, where you'll have mesenteric metastases or nodal metastases along the main arteries. And those tumors cause problems because they eventually obstruct those arteries or veins, which causes the intestine that is fed by that particular branch to die. And so those are very challenging for the surgeon sometimes because we can't take those arteries. And so those would be a specific situation where we consider irreversible electroporation. Here's another example of a patient, active patient, and you can see there's a tumor smack dab in the middle sitting between the left and the middle hepatic veins. Now I can go in there and microwave that, but we use microwave to knock off blood vessels. So I could take out 2 of those hepatic veins. Sometimes it's a calculated risk and we'll accept that, but if you've had, say, a previous right lobectomy and you're living off those 2 veins, it's probably not in the patient's best interest to thrombose those vessels. So we've had some early issues with IRE, with muscle interaction, and there are ongoing clinical studies right now, but there are no comparative studies of IRE to other ablative modalities. We are working in our lab with trying to make IRE better for the user with new mathematical algorithms, because again, it's very challenging to choose the right pulse length and voltage. We want to try to make that better. We're also looking in our lab at we have developed a nanoscaffold for drug loading, and we want to treat the porated tissue with that while you're recovering to try to enhance. And then finally, we're working on the next generation IRE system that doesn't need to be linked to your EKG to try to make it go a little bit faster. Now, at the end of the day, we can have the best modalities on the planet. We can destroy anything. But at some point, some human being or a robot has to put that applicator into the right point in space. If we miss the tumor, it doesn't help you, even though it might be the best thing on the planet. And that could be a little bit tough. It might sound easy to put a needle in a certain point in space, but I can assure you it can be challenging. So we've tried to make that better as well. And so again, this is what we've developed in our lab. I'm getting all the looks. I'm getting buzzed and stabbed, and somebody's kicking me under here. I'm going to wrap up here in 2 minutes, 2 or 3 minutes. This is an advanced image guidance system that we've developed with our partners at UNC Chapel Hill. And basically what we're trying to do is fuse 3 things together. Real-time spatial positioning. We have real-time ultrasound, and real-time is the key there, and a virtual reality representation of the needle. Now we've developed that through what you just saw, to an open system where we've done gels, then animals, then we've done the only human clinical trial, got it through the FDA, then we said, well, we do everything laparoscopically nowadays, and so we went to a whole different electromagnetic field generator with directional field sensors on the ultrasound and the needles. This is a great example of why one should consider having a laparoscopic ablation. This is what we typically see when we operate in patients laparoscopically. You saw that lesion over there that was not appreciated. There's another lesion not appreciated by preoperative imaging. And then again, when we ultrasound, I would say typically for patients with neuroendocrine disease, probably half the time we find more disease in the liver than we expect, despite wonderful imaging. Now, this is a great example of a percutaneous ablation. See, the lesion was on the stomach, so the radiologist was afraid to hit the stomach, so they pulled back a little bit and they burned the abdominal wall and got an incomplete burn on the liver lesion. So we think that there's probably some advantages to doing things laparoscopically. This is what we see in the operating room. We have 50-inch monitors just like that in the operating room, and this is our advanced image guidance system as it stands today. What you see here, that's the ultrasound floating in space. You can see the lesion there, and there's the trajectory of the needle. And the purple box is where that trajectory crosses the plane of ultrasound. So we're trying to line up the purple box with the lesion in the liver, and then we can advance, because we don't want to pass a needle 20 times through a liver. That's probably not a good thing to do. So if we can stick it on the first shot and effectively place it perfectly, the ablation will be more efficacious. So there we go, and there comes the needle. And that's a virtual reality representation of the needle, but you can see the tissue move as we push the needle through. And this is going to be the future of image-directed therapy. Now we know how big the microwave field is going to be, so we can put that in a mathematical formula. We'll We'll turn the power down so we don't destroy the ultrasound probe. And so these are some of the things that we're developing right now, which, again, hopefully will become mainstream. I'm going to try to wrap it up. I was going to run through a couple quick cases, but let me just go real fast. This is staged liver surgery and ablation. You can see multiple lesions, big posterior lesion. We went ahead and did a laparoscopic right lobectomy, let that person recover. We usually treat with transarterial therapy in between, and then we'll go back and microwave those lesions. And you can see, so even though we might not get everything on the first shot, and some of the people in this room know, sometimes we'll have to take a staged approach to try to get all that disease. This is an interesting patient. The reason I want to say the importance of multimodality therapy. This is a gentleman who had pancreatic neuroendocrine in the head of his pancreas with 9 liver metastases. So you can see his liver mets there. And what we chose to do for him was transarterial radioembolization of his liver. And then we primarily treated the pancreatic head mass with stereotactic radiosurgery. And then we went back laparoscopically and did a laparoscopic microwave ablation of all 9 hepatic metastases. And he had a pretty good durable result. And then finally, this is a nurse in the hospital who was taken to the operating room by myself. You can see it was open, so way back when. For expected 9 lesions in her liver. When we opened her up, this is what we typically see, a multiple small. She wound up having 50 lesions in her liver, and we actually microwaved all of them. I'm not saying that's the right thing to do for everybody, but we were there and we treated all 50 lesions. And then working with our radiologist, what do? We take out the gallbladder, we ligate the GDA, we ligate the right gastric artery, because we anticipate that this person will have transarterial therapy later. Where's the radiologist? Do you appreciate that? That we ligate the arteries for you? Okay. And then this is what she looks like afterwards. And she's out about 7 years now, but with no evidence of disease. So what's the future going to look like? You know, I don't know. But this is what I think about every single day. But I do know this. With all the technology and talent we have out there, I do believe that things are going to get better. So it's important to understand that ablation is well established in cancer care. It's important to understand the physics of the system, the user to understand the physics of the system. Then it's also most important to appreciate that when we're talking about radioembolization, surgical resection, ablation, that these technologies are all complementary, not competitive with one another. And so patient selection is crucial, and understanding the natural history of disease and a multidisciplinary care is most important. Again, I think a couple of people said this already. Beware of those who are making all these wonderful, great claims, and it really is coming down to a multidisciplinary approach with patient-centered care. So again, thank you very much from the HPV surgery team at Carolinas Medical Center. Sorry if I went over. Thank you. Sure.
Yes. Will the panel of speakers please come up to the rostrum now for the question and answer period?
He's one of the colorectal surgeons. Yeah. Yeah, great surgeon. You look great.
Hey, great talk.